Good afternoon, everyone. I'm Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement Forum, and I'm delighted, on behalf of Laura McGahey, Executive Director of Slaintecare, to welcome you to this webinar, the first Sláintecare Integration Fund webinar as part of our Learning Network event series. This is the first ever Sláintecare webinar, so fingers crossed it all goes well, and please bear with us if we encounter any technical problems. We're not at the RTE or BBC production levels just yet. We are taking questions later if you want to type them in using the feature that you can see there on the top right hand corner of your screen. We are very happy to be delivering these webinars in conjunction with the Health Service Executive, where so much of the innovative practice is happening, and indeed it is driven by HSE staff. Also with the support of IFIC, the International Forum for Integrated Care. Slaintecare is, as you know, about providing right care in the right place and at the right time. And we've lined up 4 webinars in which you will hear about how some of the projects funded by the Slaintecare Integration Fund are showing us best practice for healthcare reform and how they have adapted and responded to COVID-19. Many of us have been moved by the spirit of community, togetherness, and the generosity we've seen from our frontline workers, our families, and our neighbours. As part of these values showing concern for wider community, we've also seen new practices emerge in the health and social care services right across Ireland. We hope to share some of these with you in this webinar series over the coming weeks. There has also been great loss and pain for many who have fallen ill or died, and for the families and friends who've lost someone, we all mourn that loss. Indeed, some of the highest number of deaths took place in residential settings, where many of our older people are cared for. We must all be committed to holding firm to fight and defeat the virus, and remodelling our care for older persons must be a part of this. So our focus today is on the care of older people, and in future webinars in the series, we will hear from other Slaintecare Integration Fund projects which have adapted over the recent COVID-19 pandemic period, all leading to improvements in health and social care outcomes. There are stories emerging of good practices which have developed and which we think are worthy of sharing to inform how we might continue to improve health and social care systems for all, but especially we're focusing today on older persons in Ireland. We will hear how Slaintecare Integration Fund projects have contributed to the delivery of care to help older people stay well in their homes and in their communities, avoiding emergency departments and hospital admittances where appropriate. Today we'll share 3 different Slaintecare projects doing really exciting work, projects which demonstrate how older people, when supported, are enabled to remain well in their own homes with the appropriate supports around them. We'll have a chance to speak to the project leaders about the changes they've made and what they need to continue their good practices. These lessons will inform the research being carried out by Dr. Sarah Burke, Assistant Professor of Health Policy, and her team in the Centre for Health Policy and Management at Trinity College Dublin. These seminars and your comments or questions are all part of her data gathering, and we'll hear from Sarah presently about why she thinks gathering this data and sharing these experiences is so important for the delivery of future health practice and health policy. But first up today, we are joined by eminent practitioner for this first webinar, Dr. Siobhan Kennelly. Siobhan is a member of the Slaintecare Advisory Committee, and she is National Clinical Advisor for the HSE and is known to many of you as a consultant geriatrician. She is the National Clinical Lead on Integrated Care of Older Persons. Siobhan had hoped to join us live today, but she, instead of being here in person, she got called away, and she has sent us a message where she explains to us What is integrated care and what does it mean for the care of older people?
Integrated care speaks to the experience of total care for the person that enables the person to remain well and supported in their home and the community. With regards to care of the older person, we know that as we age, what we value most are the social connections with our families and communities, and a health and social care system that enables that. Within the integrated care programme for older persons, what we are developing is a model that speaks to facilitating as much care in the community as possible. The desire here is to maximise our health status as we all age through access to supports at home, ensuring access to primary care supports, including GP, multidisciplinary teams, and specialist supports in the community setting that can manage our care as our health status changes, and minimising the need to spend time in the hospital. Most importantly, improved community integrated care supports the older person in their choice to continue living at home in the long term and reduces the need for long-term residential care. This represents a fundamental shift for older persons. During COVID, we saw a massive upscale in care that was enabled within the community. We saw the massive response from the community and voluntary sector in particular that supported older people and others with vulnerabilities. We saw the process of rapid access to medical opinion through virtual clinics and telehealth. We know that these are key ingredients in enabling care for older people and others closer to home. Sláintecare is the key driver in ensuring delivery of a scalable and sustainable care.
So thank you very much for that, Siobhan. And I think emphasising there that integrated care for older people means improved community integrated care. And this very important shift into the community, of course, means that for older people, choice of where you are and where you live is improved. And I think the idea of the emergence, as Siobhan has mentioned, of the community and voluntary sector working together to make this integrated community care happen. I think we'll see this as a theme this afternoon in the projects that we're going to bring to your attention. So thank you, Siobhan, and keep up the good work and the advocacy for better, more integrated care for older people. I'm now joined by Dr. Sarah Burke, health analyst and researcher in Trinity College Dublin. Sarah, you're currently gathering evidence on the range and scope of the Irish health system's COVID-19 responses, which developed during the awful pandemic. Tell us about the origins of the research you're currently engaged in, why you're doing it now, and importantly, where will the evidence that you're gathering go? Thanks very much, Sarah. You're welcome.
Thanks, Gráinne. Prior to COVID-19, I was the research lead on a HRB-funded project, which was co-producing evidence to inform the design and the implementation of the regions. With the arrival of COVID-19, this research has responded to track, need and assess the COVID-19 responses that potentially accelerate or inhibit the implementation of Sláintecare this year and beyond. We're doing this now because COVID-19 is perhaps the biggest health policy or health system change experiment any of us will ever live through. And as it was happening, in conversation with Laura McGahey, who is the lead knowledge user on our research project, and in conversation with our partners in the Department of Health and the HSE, we spoke about how we could change the research to capture what was happening in the health system that is most relevant to Sláintecare. And in particular, we're really interested in learning about those COVID-19 responses that align with the Sláintecare objectives of universal access to timely, integrated, quality care. And we're using the Sláintecare principles as our starting point. Also interested in system change at a local, regional or national level, but a change that is scalable. And particularly interested in the mechanisms and enablers for the change. So how is that change brought about, and what can we learn from that for the health system and reform going forward? Inherent in this research is its iterative, responsive, co-design nature, and we are already feeding the learning of this research into the system in terms of what we can learn from COVID now and towards Sláintecare implementation. This research is about harnessing the best of the COVID response for Sláintecare implementation now and in the future. It's about capturing the change and the learning so that the system can continue to change and learn. And ultimately, it's about providing universal access to timely care for people in Ireland and better health outcomes.
Great, thanks, Sarah. So I think that phrase, change experiment, is a wonderful way of describing what the COVID-19 has been for all of us, but in particular for those who are working in health and social care in Ireland. So we look forward to seeing the results of Sarah's research, and I understand that those results will be coming through in real time rather than waiting till the end of the next year or thereafter to really capture in particular these enablers of change and making sure that Sláintecare is using those enablers to the best of ability. Okay, so in terms of moving then from looking at the research, where it's working, what it's going to be worked for, I'd like to move on now to the core of our webinar today. We have three really interesting integrated fund projects who are doing great work in the care of older people. Let's hear first from Dr. Rosa McNamara. Rosa will talk about the Wicklow Frailty Response Project. So over to Rosa, who's going to do a presentation about the work she's been involved in Wicklow. Thanks, Rosa.
Hi, my name is Rosa. I'm a member of the Wicklow Frailty Response team. I'm going to talk to you a little bit today about our project and how it changed as a result of COVID-19. As a group, we thought we wanted to do something differently in the way we cared for older people living in the Wicklow area who needed unscheduled emergent care at weekends. We noted at the time that there were about 10 calls a day to the National Ambulance Service for falls, and almost 100% of these were conveyed to the emergency department at St. Vincent's. The average length of stay in St. Vincent's was 22 days, and with each transition of care, be that a move from one ward to another, or in this particular group from St. Vincent's to St. Colmcille's, an extra 3 days length of stay were added. We thought we could do things differently, bringing the care that patients needed directly to their homes. Our model included an emergency medicine specialist registrar with an occupational therapist and an advanced paramedic from the National Ambulance Service attending 999 and 112 calls out of hours at the weekends in the Wicklow area. The idea was that as a call came in, the team would be dispatched to assess patients from the point of view of injury or illness, and then to additionally assess functionality, cognition, and mobility in their own home. We hypothesized that 50% could perhaps be treated at home, and we wondered if of the 50% we thought might need to come to hospital, a further 25% could go directly to the medical assessment unit at St. Colmcille's rather than all the way into Dublin and then back out to St. Colmcille's at a later date. The team had access to remote IT, so they could access any of the information systems in St. Vincent's, including diagnostic imaging and laboratory. They had near-patient blood testing for urea and electrolytes, FBC, and coags. And they could also use point-of-care ultrasound for lung ultrasound, abdominal ultrasound, particularly for bladder scanning, but also for musculoskeletal ultrasound. In addition, the occupational therapist had access to equipment as was necessary to provide to patients, and they could access additional equipment deliveries through the Slán Abhaile programme at St. Vincent's. We were just up and running a couple of weeks when, as a result of COVID-19, we realised we were going to need to change our model. There were many competing demands on resources at this stage, and particularly for the National Ambulance Service, it wasn't always going to be possible to provide an advanced paramedic 7 days a week. Equally, the emergency department registrars were in short supply, and so we had to slightly change our model. So we always provided a senior doctor, but we anchored the service now on our occupational therapists who provided a constant within the team. We also changed where we took referrals from. So not only did we accept referrals from 999 and 112, but we took referrals from local emergency departments, from GPs and nursing homes, and from our geriatrician support helpline. We also expanded our catchment area, so no longer were we confined to East Wicklow, but we now covered an area from Dublin 2 all the way to North Wexford, just north of Gorey. At this stage, we've seen 500 patient contacts and over 300 patients. Our target of 3 to 4 patients per shift has been massively exceeded, and as you can see, we have on occasion required a second car to support calls because of the high volume. So our service rapidly went from 2 to 7 days and from a Wicklow only to a Wicklow Plus service, and this was possible because of the buy-in of the various stakeholders in the project. The final model for it, I guess, is something that we have to decide in terms of sustainability moving forward. Having the occupational therapist be the anchor was certainly beneficial, and it may be that in the future a community paramedic rather than an advanced paramedic/doctor model is favoured. On behalf of the team, I'd like to say huge thanks to all of our stakeholders and to Sláintecare for their support during this project. We hope that we can continue into the future.
Great work indeed. What superb work. Rosa, the expectation at the start of the project was that there would be a 50% reduction in the number of older people who call 999, who are conveyed to hospital. You certainly appear to have exceeded that expectation. What percentage reduction have you seen in conveyance to hospital and length of stay?
So I suppose the big thing is that at this stage, less than 10% of all the patients we see in their usual place of residence actually get transferred into the emergency department. And even those that do get transferred are getting transferred for specific care or for specific diagnostics. So it has changed, hugely the way that we decide who needs to be transferred. And again, I suppose that change from a 2 to a 7 day service meant that we had the luxury of being able to follow people up rapidly if we, were trying to decide what was the best course of action. So it's made a huge difference in who gets conveyed.
Great. And just one more question at this point before we go on to look at the second video. Do you think is this way of working, is it sustainable in your view?
I think so. I think particularly we showed that when we had the equipment, when we had the kit and we had the training, that we could upscale it very quickly. It actually really was then only about finding the personnel and upskilling the personnel that would cover the service. And because of COVID, it actually made us relax a little bit about who would be the clinicians in the vehicle. So we were able to be a bit more flexible and to offer colleagues in general practice and geriatrics who were interested and had an interest in pre-hospital medicine to join the team, and that's meant that it's a much more sustainable model now.
Very good, great. We'll come back to you in a moment, Rosa, but first I want to go now to our second project that we're going to look at this afternoon and speak with Avril Heavey, who is the AgeWell Programme Manager from our second Integration Fund project. AgeWell is an award-winning, innovative new model of integrated care, supporting older people to remain safer and healthier in their own homes. AgeWell has been supported by Slaintecare's Integration Fund, And this support has allowed the Age Well programme to extend into East Meath, thus making it available to every older person in County Meath. So let's hear now from Avril at Age Well. Thank you very much.
Hello everyone, my name is Avril Heavey and I manage Age Well. Age Well is a programme of Third Age, and Third Age is a national charity which aids older people to live well and age better. I'd like to take this opportunity to thank Sláintecare for inviting me to speak at this webinar to update you on how Age Well is responding to COVID. So without further ado, I'm going to share my screen and go through a couple of slides. So firstly, I'd like to give you a very brief overview of Age Well. Age Well is a model of integrated care, supporting older people to remain safer and healthier in their own homes for as long as possible. This is done by sustained peer-based social engagement in the form of weekly visits to our clients, most of whom are referred to us from a HSE source, and combining that with mobile technology in the form of our health app created by gerontologists to pick up on evolving health issues. And it is this combination that helps us to refer our clients to the right care in the right place at the right time. Needless to say, our work practices had to change in response to COVID. So I'm going to play a very short video clip which captures how Age Well has helped one of our clients.
For John Lee, this socially distant chat is a lifeline. The 90-year-old struggles with loneliness and depression.
After my wife passing away, and shortly afterwards when my sister died, I had no one really, and I had to get help because my life was pointless at that stage.
John sought that help from Age Well in 2018, a care coordination programme for older people in Meath. And during the COVID crisis, he says, it's been even more important.
So without them, she had no one because I couldn't go out. And, you know, and I'm a person to exercise a lot. I like to get out and meet people. But when that was taken away, my life was taken away, really.
In the 18 months since Age Well was set up, it's proven hugely successful.
We've reduced loneliness by 75%, which is absolutely huge. And we've also increased their well-being, overall well-being by 40% and increased their self-rated health by 21%, bearing in mind that the mean age of these older people is 82.
This programme only operates here in County Meath, but it's hoped it can be rolled out right across the country if funding becomes available, so that people in similar situations to John can benefit too. And the 90-year-old has this message for those who are feeling down.
You have to get help. You know, I would feel myself that there's nobody there. And when you reach that point, you have to talk to somebody.
Hi, John. On this slide, I'll tell you a little more about how we changed our work practices in response to COVID. First and foremost, we carried out a risk assessment, which looked at the public health restrictions in each phase. We then put balanced practices in place to ensure the safety of both our clients and our Age Well companions. Our app is able to pick up on many of the signs and symptoms of COVID-19, which allows us to encourage the older person to seek medical help in a timely manner. We are also aiding our Age Well clients to navigate a somewhat restructured healthcare system, as we want to ensure that routine health issues are not missed. From our risk assessment, we're able to match our services to whatever phase of restrictions we're currently at. So initially, each Age Well companion was in touch with each of their clients every week and carried out the health questions from the app over the phone. We then moved to socially distanced outdoor visits like the one you saw in the video clip. And currently, we are doing in-home visits, all the while adhering to public health guidelines and using appropriate PPE. Throughout all the phases, the Age Well team are running errands for the clients and linking them into the many new COVID-specific services if required. As the phases progress or regress, though hopefully they won't regress, we can toggle, if you like, between phases to continue to deliver the programme. All of this needs training, of course, for both staff and our Age Well companions. We were lucky in that the training the Age Well companions got when they started in the programme had quite an emphasis on the technological side of things. So without too many glitches, we were able to train all our Age Well companions online to get them up to speed. And lastly, we have always assessed our clients in relation to health, well-being and loneliness levels. And we are continuing to assess these parameters. And I think this will make for very interesting data to look back at and compare pre and post-COVID, whenever post-COVID may be. So although many things had to come together for Age Well to respond to COVID, the one constant throughout all the phases is the Age Well app. And it's this that ensured we were able to refer our clients into the right care in the right place at the right time. I'd like to take this opportunity to thank Sláintecare again for inviting me to speak at this webinar, and I'd like to wish every other programme every success. I hope everyone stays safe and well, and thank you and take care.
Thanks, Avril, and again, great learning. And isn't John Lee such a wonderful example of the importance of the work and the kind of outcomes that can be had from these interventions? Our final presentation for today, before I speak to the three project team leaders, is from Sean Moynihan. And Sean is the CEO at the organisation Alone, which many of you will know is the national organisation that supports and empowers older people to stay happily and securely at home. So let's hear Sean's presentation.
Good afternoon, I'm Sean Moynihan from Alone, and I'm delighted to be here today, and I'd like to thank everybody for the invite and this opportunity. And what I hope to cover today and do justice to the staff, volunteers and partners we have is what do we do, how do we do it, the support we get from Slaintecare, what we've done to respond in COVID-19, and then some of the learnings. Alone is a merger of 5 organisations that supports and empowers older people to age at home. We do this by having an integrated system of coordination of supports, providing practical supports, befriending, phone services, social prescription, housing with on-site supports, technology and assistive technology to use support plans and create a point of contact to access a range of health, social care, housing, transport, and other areas of need that arise for the older people we serve and work with. I think our aim always is to improve the health, the physical health, the emotional health, and the mental health and well-being of the older people we serve. 2 other things we do is, 1, we provide technology, training and knowledge to other agencies to do what we do so that we can create scalable models and collectively respond to what is an aging demographic. And finally, we're involved in mapping where are the older people in need and then working with others to align services to those locations and to help people use technology, whether that's in hospital discharge or in other scenarios, so they can age safely and securely at home. Alone services operate across all CHOs, and our aim under our strategic plan is to support 45,000 older people nationally a year, to provide 27,000 of them with support plans, another 500,000 visit support and befriending visits, and 500,000 support and befriending phone calls. Also to provide 36,000 units of social prescription with the support and help of other agencies also in this area. And also we will provide training, support and technology and computerization to 100 other agencies across the country. In this area, we've had wonderful support from Slaintecare, and our Slaintecare project is about linking healthcare, social care, and community care together using technologies to benefit the older people, with a huge focus on the use of technology prescription to those being discharged from hospital, and also having a situation that we get increased collaboration, cooperation, and people using the same processes to support older people to age in place. Building on our work from our strategic plan and the work we've been doing and supported from the Sláintecare program, allowed us to switch from operating across CHOs to still doing national coverage, but we split our staff into work stream. One work stream looked at the older people and supported the older people living in our housing. Another work stream of staff worked at the older people already engaged with us to ensure support plans, social prescriptions, volunteer engagement continued with those older people. Then we had a work stream around national support line, which operated 8 to 8, 7 days a week, and that still continues. And we went through the phases probably of public health information, then working with those older people around practical supports, health and well-being, and really now supporting people as the country opens up. Fourth work stream was actually fulfilling those practical supports, whether that was around food, medication, solid heat, or other housing and general health needs people needed. This was backed up by our technical and human resource services, where ultimately that work stream of staff just making sure that our 2,500 volunteers, our staff were well supported, retrained other people who came to us at that time, and also make sure that our IT infrastructure withheld the pressures that we were under. The sixth work stream you see there is partnership work stream, hugely important. We shared our protocols, our practices, our public health information, our initiatives with over 250 agencies, and ultimately is we tried to keep in touch with everybody to also make sure that we could help create a coordinated response, including those in civil society and engagements in NGOs, to ultimately respond to every older person that came to us. Our seventh work stream was we managed to keep our Slaintecare project running, especially around using technology to map the data, the supports that we were giving older people, and the technological prescription to older people. In the centre, we had a situation where all the reports came into there, and ultimately as we provided reports and worked across the CCMA, the LGMA, and the local forums in 31 counties, and reported into three different government departments to provide them with the information and knowledge that we were getting every day. This is a nice, neat diagram, but the reality of it is that we integrated all of these services and rebuilt our quality system, so everybody coming through the national support line could access all the services that we offer and could offer. This slide shows the data on the supports we've provided since the start of COVID-19. 25,000 calls received, over 110,000 calls of support given, 16,500 units of practical support, 12,000 older people being supported on an ongoing basis, 76% of all callers living on their own, and a system to support vulnerable those who are considered vulnerable adults on an ongoing basis. The enabling factors for all of this was a skilled workforce, quality standards already in place, an IT infrastructure, and partnerships and relationships built over many years, and now new partnerships with civil society like the Guards, the GA, and An Post. The sustainability here, we think, is that this aligns to our strategic plans and goals and Sláintecare support we've been getting. And ultimately we're enthusiastic about the new interest from everybody in the use of technology and the integration of services. I think we should celebrate the capacity both of the NGO sector and also of the statutory sector to implement change at pace. And I think this bodes well both for Sláintecare and the other strategies that are in place that are around health and well-being and support of older people in the community.
That's great, Sean. Thanks very much. Sean, you mentioned in your presentation there the new partnerships that you've made the GAA, An Post, the Gardaí, and we've seen a wider community response during COVID. How would you suggest we sustain and maximise that support for the care of older people into the future?
Yeah, I think what COVID-19 has done is energised the community to support older people, and I think that civil society engagement has been huge. I think for us, the Guards as a trusted force in every community have been helping out with food, with access to finance and everything else. And we've already started a conversation with the Guards and with the policing authority. How will this impact their role going forward? They've always focused obviously on safety and security, but how do we train them, resource them, that if they see older people with health issues, with housing issues, with transport issues, have they got both the training to respond, but also the pathways and referral pathways to other NGOs and statutories to engage. Similarly, the An Post, we've been working really closely where they've been knocking in and referring people on every door. Can we get them to continue that? And the same thing, can we resource and train the postmen to be looking out for signs of issues where people may need support and offer that in an appropriate manner? So I think these are great conversations that are started, and they should be broadened.
For sure. I know in my own area, the postman has been knocking on the door of anyone whom he knows is living alone, and has been doing that apparently off his own bat for the whole of the lockdown, and people really appreciated it, and we've all come to really value him coming into the estate where we live. Let's broaden out the discussion now and welcome the other, all three project leaders that we have with us today. So Sean, we've just been speaking with, Avril, who you met a moment ago, and Rosa from the Wicklow Frailty project. Let's go back to Rosa first, if I might. Rosa, can I ask you to tell us what difference the Sláintecare funding has made to the work of the Wicklow Frailty project?
I think the key thing is that it allowed us to equip the team and to staff the team. You know, we had an idea, but trying to change the way that you do business, trying to find the equipment to do that, trying to find the staffing hours is the main barrier often. So using the Slaintecare funding to staff our weekend service, to equip it, allowed us to get up and running, and that in turn allowed us, when we became busier with COVID, to look for local partners and to look for sponsorship and support from within our local community to convert rapidly from a 2 to a 7-day service without having to go through a very complex system of procurement. So without the initial funding, we would never have been able to upscale it.
And Rosa, this is one of the questions that has come in on the live feed today, asking, was there significant additional resources required to make the project work at the rate at which you managed to make it do so?
To be honest, it was, I suppose we did co-opt a lot of different people. I won't lie to you. So there were times where we did need a second car. So particularly when the pandemic was, I suppose, when we were seeing the highest numbers of cases, there are almost 60 nursing homes in our catchment area. So there were times where multiple people were sick at once. So, you know, with support from within the 3 hospitals in the area, from St. Columkille's, St. Michael's and from St. Vincent's, we were able to find additional staff, and Toyota Ireland gave us a second car so that we could send skilled staff out to treat people in their usual place of residence without need for transfer in. And, you know, we pulled in infectious diseases and people who would never have felt like the pre-hospital environment was part of their domain. And we convinced them that, you know, at least temporarily they had, you know, something to offer. And so that allowed us then to capitalise on, you know, all those links that we've already made down the years within our local health community, and allowed us to kind of pull together as a community, as a health community, to meet the needs of our patients.
Great stuff. And coming back to AgeWell, Avril, there's no doubt that we could see the value of the work that you've been doing there. In your view, what difference has the Sláintecare funding made to your work?
Sláintecare has been, you know, made a big difference to AgeWell. There's a huge demand for AgeWell. not only in Meath but all across the country. But I mean, ultimately what we've been able to do is we started as a small pilot in Southwest Meath, and with the public health, the director of public health nursing in Meath had asked us to move into different areas, you know, where she saw a need there, and we would regularly have meetings about where the need would be within the county. And ultimately, we've been able to move over into East Meath because of the Sláintecare funding. And East Meath is an area where an awful lot of people may have moved from other parts of the country or from Dublin down to a seaside town. And what you see there then is they don't have the family backup and the community behind them. So you can see quite complex cases in that scenario, you know, both from physical health, psychosocial health, and even environmental settings, which the app picks up on. So it's really helped us to, you know, be able to say now it's a county-wide thing. We're able to gather data from both rural and urban sectors. So it allows us to look at that data in way more depth.
Yeah, you mentioned the use of the app. One of the questions that has come in on the feed from, in fact, one of the other projects, the Fatima Groups United, they're asking about, you know, were there challenges on the digital front, given that not everyone has an app or the broadband is not what it should be in some places? Was that a challenge for you?
Well, we always knew that digitally we'd have to be up and running and have it at the forefront of our mind. So what we did from the very start is only our volunteers use the app on their phone, and it's the volunteers that ask the clients. Okay. So we did really rigorous training with our volunteers in relation to that app. And, you know, we ensured that every Age Well companion had their own phone, because from a GDPR point of view, you're gathering, you know, quite sensitive data on people there, you know, and so as soon as those questions are asked, then they're completely deleted off that phone once they submit that. So, I mean, we had funded that, we had kind of looked at the funding around that to start with. So that was always the plan from the start, because we knew the technological part of the programme was the core of the programme. You know, the friendship is absolutely essential and the building up of relationships, but it's the technical part of it that allows us to really see where we need to put that help in the right place at the right time.
Okay, and finally for yourselves, again, another question that's come in for Age Well. How did you measure these parameters of well-being and loneliness? I mean, we could see from John that he had really benefited, and he was saying to other older people to reach out and ask for support. How were you measuring this from the people you were providing supports and services to?
So, you know, everybody has known up until now that, you know, social contact is so important, but, you know, nobody was able to look at the data and see, well, how important and what does it do, and how good is this social support. So what we do is we assess people before they ever come into the programme, and then at 4 monthly intervals. And we use universally recognised scales that look at well-being, so WHO5 well-being, we look at their social support, the Moss-8 scale, and then we use the UCLA loneliness scale, which is the same loneliness scale that Tilda would use in relation to their loneliness. And then we do some self-rated assessments in relation to self-rated health, physical activity, and, you know, different things like that. So they're 4 monthly, and then every second week we go through what we call the 2020, which are the questions that we would ask about their physical health, their psychosocial health, and their environmental setting. So they happen fortnightly, and then the bigger assessments looking at the well-being and loneliness happen 4 monthly. And it's great to have the data from before they started and see where they're going to.
Absolutely, the evidence base is so important. Coming to you, Sean, and again, you know, great work that Alone has been doing up and down the country. And we saw in your presentation some of the changes that you've made to your approach. What difference has the Sláintecare funding enabled you to apply in your project? So, Sean, I think you've got your mute button on there.
Apologies.
Okay, that's all right. We won't do it.
I suppose what Sláintecare has done in the funding and support from there, the project is bringing together the whole community to support older people to age at home and trying to link people across technology and, you know, this sort of the tech for good, so to speak, where we can use technology to drive human contact and human resources to support older people to age at home. And I think being part of the funding from the integration fund from Slaintecare allows us to take part in elements like this, to share what we're doing with other agencies and learn from them at the same time, so that collectively we can support older people to age at home.
Great. And Sean, if you're to pick out one change in your service, what has been that's made such a major difference in your view? What's that one big change been?
I think so. It's always hard to pick one element of things. Yeah. I think COVID-19 is producing a whole level of learning, and we've already started the review for ourselves of how our services will be after we come out of this. I think the main thing we would look at from all of this with Slaintecare would be integration and relationships. I said in one of the presentation, you can see how when given the opportunity, people can innovate and implement change at speed. And I think we have to keep those conversations going, keep those relationships going, and build on the goodwill that has been done through this, what has been a hugely negative crisis, but to create some type of legacy by working together.
For sure, for sure. And Sean, someone is asking, what do you mean by social prescription? I think it's a phrase that has come into the lexicon, but a lot of people understand it to mean different things. For you and alone, what do you mean by social prescription?
What we would always mean about social prescription would be literally linking people into social activities, creating a purpose and activity far beyond just their health, more focused on their health and well-being. And so what we would be doing with all the older people we support is in our assessments covering that area of health and well-being and social activity, and really identifying areas where we can create purpose for people and also create relationships both that can come into the home or outside the home to create activity that keep people well and active.
And I guess for many people, when we talk of social prescription, most people think of medical prescription, which is often in the form of getting something from your pharmacy. But social prescription is so much about community, isn't it? And it's about people supporting each other and helping each other, and in many ways staying well in ways that are very sustainable in the long run if we can all get involved in it. Going back to Avril in Age Well, what do you think you need, Avril, to continue the innovative work that you've been able to do?
Well, I think the support so far from Slaintecare has been really important, to grow Age Well. And, based on the demand that we're getting from all over the country, not only from individuals and from organisations and from primary care teams all around the country, I mean, the support from Slaintecare would be to grow and scale Age Well throughout the country, bearing in mind that over 70% of the clients that are referred into our programme are from a HSE source. So it just shows the need that's there for a programme like this, to grow it and scale it throughout the country.
Yeah, very good. And just back to the Wicklow Frailty Service, one of the questions that's come in on the feed, when the option of who could refer to the service was expanded, where did most of the referrals come from? Were they 999 calls, GPs, nursing homes?
It really was a mix. So we got a lot of calls from GPs via the geriatrician helpline and through the nursing home helpline in St. Vincent's as well. But our colleagues in the National Ambulance Service, even during weekdays when they weren't available to be with us, knew very well what the service could offer, and often contacted us, particularly in the morning. They'd give us a list of jobs to do.
Great. So a wide variety of referrals then, and certainly that could be built upon. Coming back then maybe to Sean finally around the changes that you've seen. There's no doubt that your organisation has, Alone was always a very well-known organisation for many years, but I guess in terms of the learning from COVID-19, for you as an organisation, it seems you've really almost completely changed the way in which you work and the partnerships that you have formed. Do you see this as sustainable, Sean, going forward for you?
Yeah, I think as I said in the presentation, we split from working across CHOs into work streams. I think we will go back to working across CHOs, but we will maintain some of those work streams. Before this, we had signed MOUs with around 40 organisations, but we have 4 or 5 staff currently in a work stream just working on partnerships. And I think we will try and sustain as much energy as we can there. With an aging demographic and with every older person on a unique journey of aging and needing different supports, there's room and we need to work with everybody. So we will try and take that learning and keep those people working with everybody else so that we can share, not duplicate, and align with as many organisations as we can.
Great stuff. Thanks to all 3 of you. So I think going back to Siobhan's input at the very beginning, where she was talking about the importance of moving to a more fully integrated community care model of care for older people, the 3 projects we've seen today are all playing their role in showing that perhaps in new and innovative ways. So really excited to hear from each of you. And I want to thank all of our guests today, Dr. Siobhan Kennelly and Dr. Sarah Burke, and to the 3 project leads for speaking to us. Our next webinar is planned for Thursday, the 16th of July, again from 4 to 5. So put that in your diary and do join us to see how so many frontline workers are making changes to improve health and care services for all of us as part of Sláintecare. We'll be back in touch with you again very soon with details of the forthcoming webinar themes. And I know that there is huge interest in looking at innovation through technology and indeed the partnership approaches that have come up today, and we've examined them somewhat. Meanwhile, I want to thank the team here who helped to produce this first webinar: Rosaline Harlan, Muriel Farrell, Ingrid Doyle, Ciara Mulholland, Jane Ann O'Connell, Andrew Hannigan and David Smith. Certainly we couldn't have done it without the big team effort from the whole team. If you're involved in a project which is promoting integrated care, please do get in touch with us by email on sláintecare@health.gov.ie, and you can watch this seminar back or recommend it to your colleagues where it will be available on the Slaintecare website. So from me, Gráinne Healy, I want you to stay safe and stay local and hold firm as Sláintecare continues to deliver on its promise that Ireland's health and care system ensures that we all have the right care in the right place at the right time. So to close out today, I'd like to call on Laura McGahey, Executive Director of Sláintecare, to say a few words as we close. Thank you.
Gráinne, thanks a million, and I'd just like to say a really special thanks to everybody who took part today, from the speakers to everybody who has signed in, logged in to the webinar. When we started with the integration funds, we got an amazing response from people at the front line with all the ideas, fantastic ideas, and we were thrilled to be able to support many of them. Then COVID hit and some projects were put on hold, while others, some of them referenced today, had to adapt at great speed to deliver their projects in a different and even more innovative way. And what we wanted to say is thank you so much to you and your creative colleagues for doing that on behalf of all of the people across the country. The projects that were paused will be unpaused in the next couple of weeks, and we expect to be in touch with you then about that. And we look forward to featuring those projects and seeing how you have fared over the next number of webinars. So thanks again to everybody, and we look forward to talking to you again soon.